good day. This is Dr. John Bennett from Miami Beach, home of Neurosurgical TV. We have the pleasure of having Chingiz Shashkin. He's a neurosurgeon, the head of the ACNS in Kazakhstan, Asia. He's going to give a presentation on how to improve DBS therapy. Before we turn it over to Chingiz, let's go through the panel to meet everybody. Hello, Ipe.
Hello.
Hi, John and Chingiz, brother.
Hi, hi. Hello, Dr. Jenkins. Hello, Mohammed.
Very good.
Okay.
Hello.
Hello, Naru. Could you please introduce yourself?
Okay, I am Nuruddin Bankole. I am come from Benin, but I am in WFNS Rabat Center training of young neurosurgery in Africa, and currently I am in internship at Tour Department of Neurosurgery and also associate research in Laboratory of Anatomy. And nice to meet you all.
Very good, Naru.
Nice to meet you.
Okay, Abdullah, please introduce yourself.
Hello, everybody. Happy Sunday. I'm Abdullah Jimo. I'm a neurosurgeon practicing in Nigeria. I'm currently in Rabat, Hôpital de Spécialité, doing fellowship in Stereotaxic, gamma knife, and neurosurgery.
Very good. Welcome, Abdullah. Abdurrahim, if I got that correctly, did I say that correctly? Perhaps not. Let's go to Ibrahim. Could you please introduce yourself?
Hello, Dr. Chingiz. Hello, everyone. I'm Ibrahim, medical student and PhD student from Berlin, Germany.
Welcome, Ibrahim. Khalif.
Welcome.
Hello, I'm Khalif, neurosurgery fellow from Kenya, currently in Valencia, Spain.
Welcome, Khalif. And Waleska Sousa, could you please introduce yourself? Perhaps she stepped away. Okay, Chingiz, welcome, and it's all yours.
Okay, thank you very much, gentlemen. Let me share my experience in deep brain stimulation therapy, and I want to deliver my presentation how to improve DBS therapy.
Can you say a few words about yourself, Chingiz, where you're at, etc.?
Okay, I will tell. I'm from. I'm from Kazakhstan. This is a large country which is located in Central Asia, and our country is located between Russia and China, and we have borders with the other Central Asian countries. We have a big Caspian Sea, we have a lot of lakes, rivers, etc. So, and we have different landscapes in our country, very interesting place, attractive place for tourism. We have our space program. We have the special place, Baikonur, where the first space shuttle went up in 1961. And our capital is Nur Sultan, former Astana city, is capital of Kazakhstan. This is a new city, but I live in Almaty city. This is old former capital of Kazakhstan, and I live in Almaty city. It's located near the mountains, and we have very nice cuisine, very nice nature. And I'm neurosurgeon, functional neurosurgeon. I work in private sector now, in private hospital, and I do mostly functional movement disorders surgery, then pain, spasticity, and epilepsy. And let me tell several words about our DBS program. It started in 2013 in National Center for Neurosurgery, and now we have experienced more than 200 cases. We have the movement disorder centers to into big cities for patient selection. And I'm a head of Movement Disorder Society Eurasia. This is the special non-profit organization, which is the main organization to distribute and share the knowledge in movement disorders in Kazakhstan and Central Asia. And we usually arrange conferences, workshops at other educational activities in Kazakhstan and other countries. And now we are waiting. I'm invite you to take a part in the second international conference on movement disorders and Parkinson disease, which will be in Almaty City, 27th of August this year. And also we do research activity in movement disorders field. And now we have research in neurogenetics and epidemiology of Parkinson disease in Kazakhstan. We use in our practice we use Elekta stereotaxic system. We call it calls G-frame, and we use Surgiplan and MRI 1.5 Tesla and 3 Tesla. So deep brain stimulation steps usually include the stereotactic frame fixation, MRI with stereotactic frame when we get these pictures, and then we do targeting using this special software. And we usually use standard targets for deep brain stimulation. This subthalamic nucleus. Subthalamic nucleus is most useful target for Parkinson disease. And we use GPI, internal segment of globus pallidus, which is more frequently used for the dystonia and sometimes Parkinson, but mostly for dystonia patients. And the VIM, ventral thalamus, we use usually only to treat tremor. So we usually use these 3 targets, and mostly this 60-90%, this is STN. So we usually do 2 burr holes in incision and burr holes in the skull. We used microelectrode recording. It's very important to define the target correctly, and test stimulation during the surgery. So while the patient usually awake, and we perform local anesthesia with bupivacaine, and it's very nice, suitable for patients. But anyway, we should prepare our patients for the surgery, so psychologically, and explain all steps of the surgery to be sure that patient will be comfortable in the OR. So after electrode leads implantation, also we use X-ray confirm. We usually use CR. And after implantation of electrodes, we usually the same day we perform IPG implantation under general anesthesia. So our experience more to 200 implantations. It was the Parkinson disease, less dystonia, tremor, pain. Even we had the case with Gilles-de-Tourette syndrome. And we have the good results in 75%, reducing motor dysfunctions, improvement quality of life, and better caring for the severe patients. The way to improve outcomes, we divide to the 3 ways. This is pre-surgical, surgical, and post-surgical. Pre-surgical issues, this is the selection. This is the main part of the very nice outcomes is the right patient selection. And the main partner is neurologists. We usually have very good communications with neurologists, and these neurologists should be trained in movement disorders very carefully, and he can be not very old, but young neurologists with a very big impact in movement disorders. Movement disorder centers, this is the multidisciplinary team. We usually have in our teams the neurologists, psychologists, psychiatrists, speech therapists, neurophysiologists, and radiologists, and other nurses who do a lot of stuff with us. And what we need the right diagnosis. For that, we usually do dopamine test. We should realize that drug treatment was failed, or these drugs are so the quantity of the drugs is very high, and we have these problems with the side effects of treatment, drugs treatment. Then we need the clear MRI. So 1.5 and 3 Tesla MRI is very crucial to find the targets, and first of all, of course, to avoid this some organic or problems in the brain. Then we should psychological readiness of the patients for the surgery, because the surgery is should be done for patients who are not in depression and psychiatric diseases, and we don't need any somatic failures in heart, lungs, and infections. And it's very important to that these patients should come to you, to the neurosurgeons, and tell that nothing to treat anymore, and do the surgery for me. So I want to show you some cases. This is the very nice cases in our practice. This is the Parkinson disease. You see this patient, this man in off state when he didn't take his drugs. So he is very his movement are very problematic. He has this after the taking of the drugs, he has these dyskinesias. This is very problematic issues for the neurology, because after the high quantity of the drugs, levodopa therapy, they usually have these such problems in their movements. So this is chorea, and chorea is very problematic for them. So this is very good patient for deep brain stimulation, and we performed this DBS for this man, and we achieved not bad, very good outcome in 3 months after surgery. You see the he doesn't have any tremor. His movement are much more better. But later he improved his movement status, and 1 year after surgery, you see this patient is very nice. He could walk. He can enjoy life, so he can move very fast, and it's very important for them, and the quality of life was very became very high in this case. See this walking is very good. Walking, you see the walking is very nice. So, and because deep brain stimulation is usually works 24/7, so we don't have any problems with fluctuations, etc. This is another patient with implanted deep brain stimulation. You see, the patient can manage the IPG. He has a special remote controller. And for example, now I ask him to switch off the stimulator, this IPG, and you see the symptoms of the Parkinson disease went back. So came back, and you can switch on again. So this video shows us a very nice, very good improvement in the movements in Parkinson disease. You see he has switched on the IPG, and now he's better, much more better. This is another case with primary dystonia. Primary dystonia is very severe disease, which usually affect these young people. And you see this young lady with the segmental dystonia, which is going to enlarge to the generalized dystonia, and this is good candidate for the deep brain stimulation. And now the 1 month later, so this young lady is much more better. So, and essential tremor is very severe disease. It looks like Parkinson disease, but it's not Parkinson disease. This is severe essential tremor. So this is essential tremor is usually could be treated with drugs, but sometimes the drugs cannot help us because of severe tremor. So you see this guy, they cannot ride this spiral. He can't manage with the glasses. He cannot eat even. Because, and after the deep brain stimulation, we see the very nice outcome. He can do these things which was not very good. And so this is the, so I have shown the 3 cases to be understandable how to improve their lives in using the deep brain stimulation. And next we are talking about the surgical issues to avoid complications. We usually divide the surgical complications, hardware-related complications, stimulation-related complications. The surgical is usually thromboembolism. We had this couple cases with thromboembolism, hemorrhage, infarction, and lead misplacement. Hardware-related it's usually because this is the because of these leads are made from the different tissue. This it can be infected and erosion, and the electrodes and connection could be broken, and technical failures could exist. And the stimulation-related and neurological failure. Sometimes when we program and stimulate patients, we can achieve diplopia, dyskinesia, dysarthria, paresthesia, and muscle contraction. It could be treated with the changing of programming. Unfortunately, we can achieve eyelid apraxia and weight gain and psychiatric disturbances. We had a couple cases with thromboembolism. Unfortunately, one woman died. So after the changing of policy of prophylactic of thromboembolism, we didn't have any deaths after thromboembolism. And when we thought about why we had these cases, we decided that it was both was a quick surgery decision, so the next day surgery. We didn't assess very well the health of the patient, and we didn't do thromboprophylaxis. After the changing of policy, we achieved very good outcomes. And so never push forward and assess the patients carefully. Intracranial hemorrhage, this is a problem because the stereotactic procedures are usually blind surgery. We don't have any possibilities to control the. Only when we planning our targets, we can reveal these big blood vessels in trajectory of the lead. And we had 3 cases. One was unforgivable and unforgettable, and non-symptomatic, 2 cases non-symptomatic. This is case when we put the electrodes in very nice target, but we unfortunately during the surgery we revealed this hemorrhage. Then we stopped our surgery and performed the craniectomy and saved her life. But unfortunately we had this problem with hemiparesis. But this woman came back because the Parkinson's disease is still hurting her. So she decided to do another side surgery. So we did it, and now she's much more better with this brain. So usually we recommend check up blood coagulation, check females for their periods because this lady was in the period. So to avoid blood vessels, we use MRI T1 contrast scans. And during the surgery, we usually chat to patient to check conscience during the procedure. And we don't use 5-channel MER because it's evident that it's much more risk of bleeding. So we use single-channel MER, microelectrode recording. And if unfortunately we have the bleeding from the cannula, we should leave it to evacuate hemorrhage as long as possible. And usually we do CT scans after procedure in 24 hours, just to check this probable hemorrhage. In 2 cases, we reveal this non-symptomatic hemorrhage after any problems. The next very high rate is infection. We saw several types of infection. So, and most cases, 90% of these cases, we should remove this device, and it's real fail because the patients usually feel the very nice outcome after implantation, but we should remove it in some time, and they become back in their Parkinson's. So sometimes we can have the erosion. This is the angle of the IPG. This is the connection of the wires, so the connection point of the wires. So why they are a little bit bigger than the other stuff, then why the skin could be erased. So we recommend to perform the surgeries in strong aseptic conditions. So we usually perform this surgery in the morning, the first surgery. We use antibiotics, of course, and check the wounds carefully after the surgery, and infection spots sanitation before implantation. Sometimes we could see the connection fail. This is very rare, but might be avoided by doctor and patient as well. We should have good relation with our neurologist who follow up our patients, and he can reveal it in programmer. For example, here we can see the high impedance. So it says us that something wrong with the connections. Then we usually use the X-ray. It's easy to just to reveal these wires, and we see this sometimes this wire is broken. And so what we should do, we should remove and change this electrode. So if there are troubles with impedance, think about connections wires. Check neurological status carefully and use X-rays to detect. And sometimes we can misplace our leads. It happens because surgeon could have a mistake, and sometimes we can do misplacement, but we can change our next step. We can change our targets and remove these leads and put them again without any problems for the health. So, but anyway, we should be very careful targeting using indirect and direct techniques. Coordinates should be double checked. We usually perform double check by two surgeons. If patient doesn't have any benefits from stimulation, or have side effects, we should check electrode position. So we usually use MRI and replace the leads as soon as possible. End of stimulation, EOS. This is a very big problem because we cannot know when the battery will be empty. So we should check our patients for the battery because it can make the sudden end of stimulation could cause malignant neuroleptic syndrome, which the percent of deaths are very high, up to 60%. So this is a severe complication of terminated stimulation. We had 2 cases, fortunately 1 death, and very high rate of mortality. So we should check battery every year. And since 4th year, for example, for Medtronic Activa PC IPGs, we should check it every month. And we can to teach our patients to check themselves, and usually have the 1 extra IPG in our stock to perform the emergency changing of battery. So think about end of service that might appear abruptly, and for this monitor. And final recommendation for all surgeons: fight for patients and don't give up, because our patients usually fills up us and believe us. Thank you very much for this, my intention for my presentation, and I can give my answers for your questions.
Thank you, Dr. Shashkin. That was a great look at Kazakhstan as an introduction and a great presentation. So let's turn it over to the panelists to have comments or any questions. Abraham, do you have any comments or questions for Dr. Shashkin?
Thank you, Dr. Cengiz. Beautiful presentation. I wanted to ask how far has DBS progressed for psychiatric indications? You've mentioned Tourette syndrome, I think. How does that go?
Yeah, thank you very much for your question. So psychiatric indication for deep brain stimulation is very, very interesting for me and for other functional neurosurgeons. And I have this experience in Tourette syndrome with very nice outcome, but we usually still use these drugs, medications, but it's no problem because usually they very good tolerated with medication, and additionally when we use this deep brain stimulation for anterior GPI, it's very nice for the outcomes. And now we have the new data that it could be deep brain stimulation could be used for schizophrenia treatment, OCD, depression. So it's very nice, very useful. Deep brain stimulation is very useful for psychiatric disorders, and you know that the number of indications is increasing every year, and now we think about the very good, for example, Chinese guys, they have oh sorry, they have very nice experience in addiction treatment also as well.
Thank you. Because I feel this is always an ethical topic, right? There's probably regulations and everything that keep the field from accelerating maybe a bit faster.
Absolutely right.
Okay, any more comments or questions? Hey, let me get you off the screen share there, Dr. Shaskin, so that we can see you full. Okay. Okay, very good. Any comments or questions, Abdullah in Nigeria?
Yes, thank you so much, Dr. Shashkin. I believe this presentation is basically for me before the benefit of others, because I'm actually currently in Rabat for fellowship on stereotaxic, gamma knife and functional neurosurgery. Actually, I followed you in details, all you've talked about, because that is what I'm here for. I've actually benefited a lot in getting a recap of what the whole thing is all about, and it was very exhaustive. Thank you so greatly. It was a very important presentation for me. Thank you.
Yeah.
Thank you, Abdullah. Khalif, anything to add or ask Dr. Shaskin? Oh, Khalif, I think we lost you there.
Hey, Chinggis.
Hi. Yeah.
Chinggis, we need to start functional neurosurgery here in Nepal, number one. And number two, we are starting we're starting the Central Asian chapter of Neurosurgical Coach. So
yeah.
In Kazakhstan, in Kyrgyzstan, in Tajikistan, Uzbekistan, these places we're going to start our program, and then we are going to these countries. We are going to be doing dissection classes, live surgeries and things. So Chinggis, you will need to coordinate everything for this.
Yeah.
Very good.
Okay, of course. We need Central Asia needs in very good classes, very good workshops, and of course dissection courses, because nobody before done here these dissectional courses. And you know that we have a lot of neurosurgeons, and they need this educational activity from us here. So let's start it.
Doing this in Tajikistan for the beginning.
Yeah, of course. So end of this year, January, let's meet in Dushanbe and discuss about it, okay?
Yes. Also, in July, I'm coming to Africa, Tanzania primarily. So we are going to have some live surgery in and after that, we hope to have some dissection courses in Africa as well.
Okay, great. Oh, great.
Very good. Other comments or questions? Khalif, you have any comments or questions? So I keep bothering you, right?
Okay. Thank you very much for attention. Thank you.
Okay, very good. I guess we'll wrap it up for this week. You can hang out after I finish. And so, what are you up to this week, Ike?
Beg your pardon?
What are you doing this week?
Well, I'm off to Delhi tomorrow, so I'm going to be seeing some instruments, and we are modifying the entire neurosurgical armamentarium. We believe that the neurosurgical instruments are more than 50 years old, and then this needs to be modified. So I'm going to a factory, and we are trying to modify some instruments.
Very good. Okay, thanks everybody for coming. And Chinitz, we'd like to see you more online, and we'll try to arrange the neurosurgical coach and get that going. And let me just quickly show you something here. This is from Kazakhstan. This gentleman presented at a conference in Spain. He's associate of yours, right, Chinitz?
Yeah, I know him. He's my colleague from Almaty. He works in another hospital, state hospital, and he is very nice in endovascular procedures. And so I have, I'm in touch with him, and no problem. We can.
Yes, we'll get him.
More people, to deliver the presentations here.
Yes, we'll get him involved too. So thanks everybody for coming. Just stay here, and I'm just going to stop recording. Thank you.